Good morning, commissioners, and over to you, Chair Harrington.
Thank you, Clerk Moss, and welcome everyone to Tuesday, December 2nd, and our full day of meetings. This is Chair Catherine Harrington. In our work session, I'm joined by Vice Chair Commissioner Pam Treese, Commissioner Nafis Fai, and Commissioner Jason Snyder. Commissioner Willie will be joining us later today, so he's excused this morning. He may be joining us for the 10 o'clock meeting, either in person or by Zoom. All depends on when his plane got home last night. He encountered some delays. So for this morning's work session, the first item is formal agenda item discussion. I have a question. I don't have anything on the Housing Authority Board of Directors meeting. Does anyone else? That's the first meeting. The next meeting, our business meeting. We have 11 items on the consent agenda, and for our first time approving the reimbursements for director travel to WEFTEC. We don't have to take that off of consent to action, do we?
You don't have to, but in order to avoid any appearance of conflicts of interest for Commissioner Snyder and Willie, it would give them the opportunity to abstain, approving their own reimbursements to themselves. So it's squarely in the purview, but any appearance, that would be the request.
What would you like to do?
It was recommended that that be the process that we use, and I am going to want to make an extremely brief comment too, because the materials I think that were posted don't include some information that I want to make sure is stated, but I can do that very briefly.
Should we pull the item for next week to get that corrected, or just?
I don't think that's necessary.
Okay.
And it'll be available in public record.
Okay, so we will pull item 2 off of consent, leaving us with 10, and move the action item to.
You can move these actions since there will be 2 motions. You could just move them ahead of the other 3 action items. So they'll become items new G1 and G2.
But we only have 1 on the consent agenda.
Yeah, but you would have 2 motions, one to approve Commissioner Willie's and then one to approve Director Snyder. So it's
They
one
didn't
item.
set it up that way.
Yes.
Okay. Yes, but I'm asking about positioning it on the action. Do we make it items 4 and 5? So we're switching from CWS to LUT, LUT, then CWS, CWS.
Yes. However you would like to do it.
We can do it that way if that's fine. We'll do Jason Snyder first, followed by Jerry Willie, following the alphabets. Okay. Are there any other questions that anyone else has on any part of the board agenda? Okay, so we're done with that. We'll now move on to the Mountain Creek Road Local Improvement District Citizen Advisory Board membership changes. Welcome.
Good morning.
And why do we use the word citizen?
That is how they have it stated in their RNO, your RNO. That is how it is listed as Citizens Advisory Board.
Right, I am.
So Mountain Creek Maintenance Local Improvement District, which we call the MLID, Citizens Advisory Board. The Maintenance Local Improvement District is, I believe you all know what it is, but just as a brief explanation, it's a public road that's not established as a county road. So they have set up their own means of paying for maintenance amongst themselves.
And you are Sherry Gray, the Community Programs Coordinator in Land Use and Transportation.
I am.
Thank
you, Chair Harrington. I apologize.
It's okay.
And so every time that the Mountain Creek Citizen Advisory Board changes membership, they need to seek approval from the Board of Commissioners. And so we have 1 resignation, Joel Robnett, and then 3 new members, Dave Sanders, Kendall Von Heer, and David Smith. And they serve indefinitely. There's no set term. And that's the entire presentation. So if you have any questions, I'd love to answer them.
So we had further information in our work session packet. Does anyone have any questions? Otherwise, we will have this item come to us at an upcoming board meeting.
December 16th.
Terrific. Thank you.
All right. Thank you very much.
Next, we're going to move on to an update on the Center for Addictions Triage and Treatment following a wonderful year of completing the construction of those two sites. Good job, team.
Thank
Welcome.
you.
Well, good morning, Chair Harrington, Commissioners. I'm Nick O'Cone, and I'm the Division Manager with Behavioral Health.
And I'm Kristen Burke, Special Project Supervisor with Behavioral Health.
And as you mentioned today, we're going to be providing an update on the Center for Addictions Triage and Treatment, which we have endearingly called CAT for the last 6 years as we've been in development. And today's going to be a fun and exciting conversation, really updating everybody on where we're at in the project and what services it look like since we've gotten started. So the purpose of today's presentation is to provide an overview of new services that have come online and are available to the community, to provide an overview and summary of the project implementation, kind of how we've gotten here, and then finally to provide an update on the current project status and what's coming next. So a little bit about project history. As I mentioned, we've been talking about this for 6 years now, and we've come to your board kind of every step of the way to look at feasibility, to look at a financial analysis, architect selection, site selection, and today we're going to be talking about what things look like now that services are up and running. We have 2 buildings up and running, and we're going to be talking in detail about what that's looking like.
I did want to provide just a really quick summary of the construction process and a little bit of reflection on that, just because it was such a large part of the project. So we did finish on time, and I will say barely. I believe we got our license to operate the Beaverton site, the OHA license, at about 4:45 on Friday before we opened on Monday. So we did get it. So we're very happy about that, just in time. You know, overall, the construction went really well. We had very few unanticipated. Yeah, we were very happy with how the construction went. And I noticed that I put this on both this slide and the next slide, but a big piece of that is we had really great coordination and a great relationship with both the architectural firm and the construction management company that really managed the project. And that really made a huge difference throughout. I'm going to talk about the budget here a little bit, because I think that's a big piece of the construction process. Early on, when we presented the financial analysis, we did talk in this board meeting about having a healthy contingency in order to really respond to any unanticipated things that came up. We did have a few things. In the grand scheme of things, it was pretty minor, the sort of things that came up. And we actually did also make a few adjustments along the way, things like cleaning up the ceilings a little more, you know, as we discovered things. Overall, I actually have a few numbers in case you're curious. The overall construction and actually the whole project budget. So this is also some of the feasibility work that we did, as well as some consultant costs, that sort of thing. The total project budget was $62.3 million. That's what has been in all those quarterly financial reports that I have shared. We are on track to spend right around $60 million, which will leave us with a little over $2 million in contingency funds left over. So we used about $1.3 million of the contingency funds. There are still some expenses coming in. There's a few things that we felt like we needed to adjust after construction, and so we still have a few things coming in, but we are going to end under budget.
Now, is this just Beaverton or is this?
This is both sites combined. I did run the numbers.
Repurposing 2 buildings.
Yes, exactly.
And building a new third. I mean, come on, you're downplaying the accomplishment here.
And during such an inflationary time where it was really hard to target what those numbers were, I think that that's another important factor as well.
Definitely.
You all need to feel very proud.
Yes.
Well, and I want to give a shout out to Stuart in the back with facilities, because he was really the person who managed the contract from the facilities perspective. And overall, our contract, we ended up, again, through some of the choices on our end, but overall, both the Beaverton building and the Hillsborough building ended up about 1.5% higher than the original price, which in a scale of how big and how complex these projects were really great. So great kudos to our facilities for all the work that they did to manage the project. So this slide is titled Lessons Learned, but this would be more like Kristen's do-over wish list. If I had the opportunity to know now what I know now back then, these are a few of the areas that I would have.
But isn't that always the way?
Of course.
Hindsight's 2020.
And I figured that you guys are all going to look at this and be like, oh yeah, duh, that makes a lot of sense. But for me, this was really, for me, kind of like, if we did this again, these are the sort of areas I would focus on. The biggest one is it essentially ended up being two projects, two separate buildings, two projects, and we could have definitely used some additional staff support just because it's complicated. When you have two different buildings, you've got two different construction teams, two different architectural teams. I think there were times when Stuart and I felt pretty stretched, but we muddled through it. There were a few late changes that added cost. I think we spent a lot of time talking about acoustics throughout the project, and it still ended up being something that we needed to do some adjustments at the end. And then the provider's needs, it was complex, especially the Hillsborough site. We have 6 different organizations sharing a space, and 6 different organizations each have their own needs for their space. And so the coordination with all of the providers was challenging, especially because some of the providers didn't even come on board during the design process. And so that was just one of those areas that it was challenging, but we worked through it. And again, the partnership that we had with everybody involved really helped us get through all of those issues. So now just an update on what the current status is on both of the buildings. I'll start with the Hillsborough building because that was the building that opened first. We opened it in June with the county and our Hawthorne Walk-In Center Crisis Services moving in June. And then most of the other services came online in July. And so with the exception of Virginia Garcia, and Virginia Garcia just opened on November 17th. And so they are really, really fresh early in their tenure there. But I have some numbers in terms of the folks that we've served. For outpatient services with Solutions Group Northwest, they've enrolled 137 people since we opened, since they opened in July. One of the cool things about that is that 30% of the folks that they've enrolled are Spanish speaking. And so they're providing services exactly to the population that we were trying to reach out to.
And would they have served that many people without this?
No, because they have a site in Beaverton, and these are new enrollees. These are not transfers. Our peer recovery services operated by the peer company. So this is our peer drop-in center. They've had 177 unique individuals come through their program. They've had a lot more contacts than that, but 177 unique individuals. Project Homeless Connect has really been supporting the other programs, and they've had 105 enrollees so far since they've opened. That's pretty amazing. They only have 2 staff on site. So 105 people supported with only 2 staff is pretty great. Again, health services just opened. I did want to say we're really excited about having the health services on site. They are actually having a practitioner, a clinician on site 2 days a week for half days. And so they'll be providing primary care and other sort of health services. But they're also staffing medical assisters on site 5 days a week from 8 a.m. to 5 p.m.
What did you say?
Medical assisters.
What is that?
Yeah.
So these are folks that are really their role is to help people get connected into appointments, into primary care, following up with helping to get connected with OHP and, rides to services and all those sorts of things, that the care coordination that occurs behind the scenes to help people get to services. And so Virginia Garcia is staffing people pretty much during regular business hours, 5 days a week, so that when Hawthorne has somebody on site who says, well, I need a primary care appointment, I haven't had something for 5 years now, they can walk them over to Virginia Garcia, and those staff will navigate the health system to get the folks connected to care right at that moment.
Does that include dental?
I believe, yeah, they can do dental as well. Yeah. Crisis services. Now, this was an existing service, but since we've moved into the new building, we've had 670 folks come in to the Hawthorne. That doesn't include MHRT. That doesn't include outreach into the community. That's just folks who have come on site.
600?
670. And so they're busy. They're very busy, and they're not open 7 days a week yet. And so that's quite a few folks every day. So overall, it's it's exactly 1,089 contacts, or enrollees, I should say, into the services since we opened really in July.
That's the one site you.
That is at the Hillsborough site, yeah.
And I think the important thing that I'm thinking about here is the fact that those people would not have been touched otherwise.
Many of them.
Many of them.
Yeah, exactly.
Does that astonish you, those numbers at all?
I was really excited. I reached out to everybody on Friday and said, "Hey, send me your current numbers." And I was very excited when I saw how many people have been served. And we're just ramping up at this point. This is the ramp up phase. We expect it to continue to grow over time.
What's really exciting is that we've seen this many people, and when we talk to our peers and when we talk to our providers, they're eager to see more. Like our peer greeter who's up front, she wants to see more people coming through the door every day. And so we're in a good space.
Yeah. And the peer company, which is operating our drop-in center, when you talk to them, they have a plan for how they're going to do community engagement, social events on site. They want to start a teen program to really target teenagers and bring them into the building. And they're really the front door. They're the ones who are helping people come and see the building and know what services are available, so that when they're ready, they're already familiar with the building. So we're really excited about how they're approaching this and the enthusiasm they're bringing.
What is the chatter, if you will, with the providers?
So the providers on site, I was actually going to get to that in a little bit, but I can do it right now because we're on this building. So we actually have a number of work groups that are on site, which bring together the different organizations that are part of the CAT. And we started the work groups about a year before we opened and have been meeting ever since. And what's really amazing is to see how supportive each organization is of each other. And so when Virginia Garcia was opening, they were like, okay, let's figure out how you get a referral to us. Let's figure out, how, if somebody is over at the Beaverton site, how do we see them? Do we hold specific slots just for this site? Do we send staff out there? That sort of thing. So they're really trying to figure out how to work as a unified group, not separate organizations. And that's, I think, the type of time when you're kind of going, wow, this is working in a way that we hoped, but it's really actually working.
Truly client-centered.
Very much so, yeah. And Nick's going to give a couple anecdotes towards the end about just what we've seen on site from a client perspective.
You weren't supposed to spoil
Sorry.
that. Yeah.
The Beaverton site, now this site just opened November 17th, so this is really, really fresh and new. Currently, they are operating with withdrawal management services, also known as detox, men's residential and women's residential. The withdrawal management services are actually at a reduced capacity right now as they're finishing hiring and training staff, but they expect to be at full capacity within the next 2 to 3 weeks. So they're just trying to get the final staff on board.
Is that what we're calling, what we have called sobering?
Detox.
Detox. Okay.
Yeah. Yep. And I'll talk about sobering here in just a second. The men's residential program, as of this morning, have 17 out of their 24 beds filled. So they're really getting pretty full. And then the women's residential has 9 folks on site as of today. They expect to fill both programs here pretty quickly. Men's will fill first, but the women's program, they're doing intakes every day and getting people in. The really great thing is that we're seeing the program work as we had hoped, which is the folks that are being admitted to withdrawal management are moving into residential treatment. That's the point where we often lose people because they're not in the same building typically. And so people will finish their withdrawal management and then they may or may not engage in other services. But we're finding that clients are choosing to go into residential treatment at a higher rate so far. And we think it's because they're already in the building and they're already familiar with what it looks like. There isn't that unknown factor for them. And so that's exactly what we were hoping would happen. Future services, so sobering, that will be the one where police can bring or family members can bring somebody who is acutely intoxicated, have them come on site and they'll receive basically supportive services, fluids, monitoring, until they're safe. And then hopefully that'll be an engagement point into withdrawal management services or residential services. We anticipate opening that in the spring. We want to get everything really working well with residential and with withdrawal management before we open that program. And then we've talked about transitional services. That's the 6-bed transition supports. That'll come at a later time as well. That's a lower priority than sobering. So sobering's our next priority for opening, and then we'll work on transitional services.
Do you think the transitional supports will be done by the end of 26, or is there the possibility that it might have to move forward?
Oh, I believe it'll be in 2026. I think the wild card for transitional supports is the funding. And that's also slightly true for sobering. And I'll talk about sobering in just a second. So,
okay.
I have a
yeah.
question. One, you said 9 beds are filled for the women's side out of 16.
Out of 20 to 24.
20.
They are
The men
flexible.
is for sure 24.
Mm-hmm.
I thought the women were less than the men. Is
So
it even number?
So the units
Sobering.
Finish.
Yeah.
Sorry, the units each have 28 beds. They're just exactly the same, 14 double beds. They're both licensed for 28, but our target number of clients would be 20 to 24 for women, and then around 24 up to 28 for men. We want to keep some of those beds open so that we can have room to admit people. It's always important to have a bed available if somebody needs to be admitted that day. But also because there's a milieu aspect. And so if you have a particularly challenging group of people, you want to have fewer folks on site. So it's a lot about just how the provider manages the services to make sure that it's a comfortable environment for everybody.
And then the other question I have is, I'm not sure I was tracking correctly the future services, the sobering and the transitional support. Could you just one sentence?
Yeah, so sobering is for folks who are acutely intoxicated, and that program will open in the spring. We don't have a specific date, but we think it'll be pretty early in the spring. And then transition services, we don't have a specific target opening date. We want to open sobering first and then start working on transition services. And that's also dependent on us having funding for that.
And what does transitional support does?
Oh, Thank you for asking. So that is really designed to catch people as they're transitioning out of other services. So if we have somebody in men's residential who's ready to move on, but maybe they're moving to a new environment, but it's not available for a few days, they can go into transition services. The goal is just to use it flexibly. Also, if say we have somebody who's ready to move on and we need that bed for someone else who's transitioning out of detox services. It's really a management tool for the provider to help with the flow of clients in and out of different services, with the goal to keep people on site as long as possible and engaged as long as possible.
Final question on this slide is, do you anticipate, or what do you anticipate the capacity would look like for sobering, especially when beds are fully occupied?
Yeah. So sobering is going to be one of those programs where it's going to vacillate from nobody on site to up to say 16 people on site, and it could change hour by hour. It's a short-term program. People typically won't be in there for more than 12 hours, generally less, maybe only a few hours. We expect that there's going to be times when it's really busy. So think about big events, New Year's Eve, that sort of thing. And then times when it's really quite empty. So it's more about having that capacity and the ability to flex. There isn't a hard and set number of people. We've always said 16 beds, but it's really a little more fluid than that. It's about what can be managed safely with the staff.
And it's a different setup, is that correct? It's not like individual rooms. This is a group room where people are managed.
Exactly. 2 different rooms, one active and one quiet. Yeah.
And then the age still 18 and above.
Yep. Adults. Yep.
Thank you.
So can you imagine people coming from the residential services into like the Cornell transitional housing? Is that a path? Is that
Absolutely. That'd be ideal to have, again, those supports in transitional housing for the folks who have housing instability. Absolutely, that would be an ideal pathway, and that's one that we're looking at as the Cornell Road is being developed. I already touched on this a bit around service coordination. We have multiple work groups that are actively meeting to look at different areas to make sure that we're coordinating, really planning for the unexpected. So we've got our service provider work group that is really focused on the providers coming together and working on things like coordination, communication, referral pathways, those sorts of things. HRC is our Hillsborough Recovery Center. We have a safety committee made up of all the different providers in the building, and we're talking about things like crisis response, trainings that are needed around things like CPR, fire drills, things like that. We have our public safety work group, which is primarily focused on the Beaverton Recovery Center. And the reason for that is it's really focused on the communication with first responders. How will they bring people to the site? How do we get ahead of any issues that might come up? So it's really focused on communication, and we have a really strong relationship with Beaverton Police Department, Hillsborough Police Department, and the Sheriff's Office, of course. The Beaverton site's in a really unique location where you cross the street and you're in the city of Hillsborough. So we've been coordinating very carefully with all of the law enforcement agencies supporting that area. And then finally, the health services work group is a new work group that we put up to really make sure that we're using the supports from Virginia Garcia in the best possible manner, looking at referrals, coordination, how do we get clients from one site to the other. And then also that group is starting to look at whether we do want to integrate a pharmacy into the program. So we're starting to look at numbers, need, capacity, that sort of thing. In that work group.
I didn't hear you on the slide mention in the public safety space, kind of the work with policing agencies in the southeast part of the county. This is a regional facility, right?
Absolutely.
Okay. I mean,
And they've
would-
been very engaged up to this point.
I would not exclude them from your discussion.
Absolutely. So just to be clear, every police agency has been invited to this work group and will continue to be invited. But one of the things that we're working on in that group is how do we inform all the agencies, the actual on the street officers about the program. And so we're developing some trainings and we will be going out to the different law enforcement agencies into their briefings and actually meeting with the officers on the street to tell them about the program.
I'm guessing they all will love it
I believe they will.
compared to what was available previously.
And a lot of it too is just setting up expectations as well. We don't want them to think that this is the be all end all to everything, but a resource in addition to other resources that are already available. Okay.
So this is a slide where board members, we need to spend time understanding the here and now.
So I want to start by just acknowledging that there's no county general funds going towards the operations of this program. This program was designed with an eye to how all of our other community behavioral health programs operate, which means we're a funding source, but we are not the primary funder for the services. The services are typically funded through a blend of Medicaid, state general fund dollars, and other sources that the providers may have, such as grants and that sort of thing. That's the same model we're doing with this program. The vast majority of the folks that we serve, we anticipate will be Medicaid. We did some research prior to opening to look at what percentage of clients we would expect to be Medicaid. Our providers are also working on getting on commercial insurance panels to be able to bill those panels whenever somebody with commercial insurance is served on site. So essentially, it's a billing model where providers provide a service, they bill insurance. However, we do know that there's some gaps with that. And so we developed the model using some of the state general fund dollars that we get to provide support for some of the areas, such as the Peer Drop-In Center. We've also reached out to some of our local coordinated care organizations and asked them to provide grant funding for certain elements of the program. So our Recovery Drop-In Center, our CCOs are contributing to help cover the cost of that. And then also we have we have a lot of opioid settlement dollars that we're using to subsidize the program and fill in some of the gap areas. So for instance, we identified very early on that we needed a peer greeter in the main building in Hillsborough because it's a big space, it's complicated because there's so many different organizations in there. And so we're using opioid settlement dollars to fund that peer greeter who literally will help people navigate to the right program when they don't know where they're going and as they enter the building. And also using them to engage with people and help them kind of identify what services they need.
Is that so? The using the opioid settlement money, I get that it's supposed to be used for things like this. Is the way that that's set up financially right now sustainable for a long period of time? Like, are we just using the interest we're earning off of it to pay for all this, or are we actually spending down dollars that eventually won't be replaceable?
So kind of a yes to all of that. So we are receiving opioid settlement dollars that are really front loaded and they will diminish over the next 15 years. And so we have a plan based on a diminishing amount about how we will be decreasing the use of those dollars throughout the next 15 years. Yes, when we get to year 15, we don't have a plan at that point about how the peer greeter would be funded, but we have a lot of time before that and things are likely to change. So planning that far ahead is really challenging. But we do have a glide path for all of these services that are funded with opioid dollars to reduce them over time to match the amount of money that we're bringing in and to not become so dependent on them that we hit a cliff at the end.
I have a question. So so we've talked about the funding for the actual service delivery models, right?
Mhm.
So what about the funding for the facility costs?
So they're both county-owned buildings, and so they're paying into the facility fees, just like any other space.
Okay.
With the Beaverton building, we have a lease with Coda, who's the operator there. And so they're paying directly to facilities a monthly cost that is based on our facility fees.
And that includes all utilities and all of that.
Yes, I mean it's a little nuanced because they're covering garbage, but we're covering electricity. So it's a little nuanced, but yes, that is the intent. And we are using some of the opioid settlement dollars to help subsidize initially, because they are not fully up and running at this point. They're not getting all of their billing revenue at this point. So we're providing a fair amount of startup dollars to help cover all those costs, including the building fees.
Can I answer it in a different way? There is not general fund that is supporting the facilities. Through the cost allocation plan, the opiate dollars, the other sources of funding are covering the facility fees.
Okay. Thank you. Okay. Other questions on funding? Okay. And now I'm going to ask Nick to take it over.
So this slide is really looking at our next steps, and we've covered some of these. But before we get to the next steps, I just wanted to share a little bit about what things look like today, because we had a vision of having this be a program that worked fluidly, where the community could enter one space and be transitioned quickly to another, and we're seeing it on the ground, and I just wanted to share that. So as Kristen mentioned, we moved in June, but a lot of the services in the Hillsborough Recovery Center didn't come online until July 1st, and so we had a gentleman who was going to Hawthorne, and subsequently he was coming into our space. He was just trying to figure out what this space was, and it was large, it was open. Sometimes he was a little on the agitated side, and our program manager chatted with him, bought him a Coke from one of our vending machines, and just let him know, we built this for you. This is your space. He came back before services were up and running, and we saw him buying his own Coke and sitting down and hanging out. Eventually, the peer company moved in, and that first week before we had a greeter, our program manager walked him over, introduced him to the staff, and he is now firmly connected with that program. Just an example of this being a wide open space that we had input from the community about what it should look like, and somebody feeling comfortable day one. And then recently we got to really feel it when we hosted a Tri-County HHS leadership meeting where we had the HHS directors from Multnomah, Clackamas, and Washington counties together. We had the behavioral health directors and the public health directors as well. At the end of the meeting, we had a tour of the building to share our space, to let people see what had come together. And almost on cue, a gentleman walks in and he's like, "These guys are the best. They are the best. They saved my life." And he went through, he talked about the peer company. He talked about the other supports he was getting. He went around and shook everybody's hand, including, I think Mira gave him a high five. And you just felt like the space, that it was alive, that people felt comfortable, that people felt supported. And he just walked in with his bike and couldn't have felt better about where he was at. So we're seeing it, we're feeling it, and it's like been a really, really exciting part. And so we're here today, and what we're hoping is to have these stories now that our Beaverton building is open about same successes with residential and the same successes with withdrawal management. And then we're going to have sobering coming online in spring of 26. As Kristen mentioned, we're evaluating our pharmacy needs and options. Is this feasible? And how do we bring somebody in to really kind of be that final piece of our Hillsborough Recovery Center when we get there?
Can I inquire a little bit about that? One of the things that you have helped the board members to learn about is, and I don't remember all the terms, but something like, I think a lot from my family experience about alcoholism, but I've learned a lot from all of you about drug intoxication, whether we're talking heroin, fentanyl, so on and so forth. So you've helped me better understand how important it is that there are methadone clinics, for example. And once again, I don't have the right terminology down for what type of service that is. I know in the Beaverton space, I thought I saw some controlled substance utilization to help with people's sobering, withdrawal management, and recovery. So I'm wondering, particularly with the Hawthorne Center or for more outpatient, is that the kind of pharmacy needs you're looking at, or is it connected with the VG health services?
I can. So yes, again, it's
Once again,
actually
having
a lot
a vision of need and grounding that.
So we're not looking at opening a methadone clinic on site. That we have resources for that in our community, and yes, we do have. We're able to start methadone in the Beaverton site, and that will be transitioned to one of our outpatient methadone providers in the community. However, in talking within our health services work group about what the needs for the pharmacy are, Hawthorne identified, the ability to provide on-site injections for some long-acting medications would be a game changer for them. To be able to just walk somebody over and be able to offer that same day could really be impactful for a lot of individuals.
Okay.
And then also health meds. They said, it's really common for people to come in with uncontrolled high blood pressure, and just being able to write a prescription from Virginia Garcia and then fill it on site that day. You're really looking at the whole health of the individual, not just the substance use or behavioral health need.
Okay, thank you.
And then our final focus, as far as next steps, is just a long-term sobering funding solution. We received a legislative allocation that's going to cover the first 2 years of operating costs for sobering. And so that, combined with our opioid settlement funds, has us very stable. And we're going to be partnering with our Medicaid provider organizations, with the state, to be able to elevate outcomes that we're seeing. And how do we look at a long-term funding solution, because it is not a billable service today, and we anticipate that will hopefully change, but we'll be leaning into that over the coming years.
Okay, I have some questions. Doing the Catherine thing, I always look forward. So I'm going to start with, let me just go. You came to us in 2019 with, there's a community need that is unmet, and you engaged very successfully with the board and asked us, would we be willing to lean into this opportunity? And here we are in 2025 with the opening of each of these 2 buildings, addressing thousands of people already in the first 6 months. Just amazing. So we've gone from vision to reality. But now I'm thinking about, okay, there, ordinarily in my brain, I think about first-year operations, right? And I now believe that my model was a bit incorrect. It's not a simple first-year operations. I see at least a 2-year operation, where you need that 2 year to better understand what the overall annual flow might be. Okay. But I'm also concerned about transition points. If I was to continue on this board for another 4-year term, I don't believe I would need the same level of financial understanding that you have been very willing to provide me with. So I could, during our cut budgets still understand how we're not over our skis. We're not overextended. We're very pragmatic about all of this. So use that as a context. I have been spending the vast many months thinking about the next stage and also learning not just about the board, but also mayors and city councils and change over there. These two recovery centers are an amazing gift for our community. And we need to make sure that it is easily digestible for those boards to understand what is now available in our community. So, Ms. Angie, this is where you frequently have heard from me, like with the first in the nation housing, where we had a 3-year construction of over 10 different sites with the private activity bond, having a case study, 2 to 4 pagers on that. We need a 2 to 4 pager on CAT and the Beaverton and Hillsborough recovery centers as they exist today, with a little graphic about, okay, we had the vision to construction. Now you've got this 2-year of operation. In that time frame with the board, they're going to need to understand how to lean into the support to get necessary services like sobering that aren't ordinarily billable services, to work with you, or to lean into the future financial frameworks you'll come up with. But I'm also thinking about this 4-pager living for 10 years, right? With those new boards, with the new city councils and mayors. And then you talked about that 15-year ramp down of funding. That 4-pager needs to have just a brief explanation about the funding sources and that timeline. But 5 years from that 15-year point, please plan a solid review with the board. One thing that I've learned with the 3 different board compositions we've had is 5 years before a cliff, we need to really take stock and be mindful of the options that our county administrator and her team are working on over that time period, and how to positively lean into those needs. Because one thing you've absolutely done here over the last 5+ years, since 2019, is to surface challenges and move us from being a derelict county condition to we've advanced considerably. And I want to try and hope that you will continue to advance. But I also can't, I also need to see something. Please follow up with a brief explanation of, are we now, do we now have a facility that Multnomah County's had for ages, or have we just advanced a little bit in our tri-county area, or what? So those are all my questions and information needs, not for today because time is short now. We've got to transition to our other meetings, but I've just totally emptied my brain in terms of information.
Can I make
Yeah.
second 1-minute comment in response to that? I would actually ask staff review and update that document on an annual basis, because things could change. This is a very new facility. Funding could change. And I think that way it is just fresh. And so if something happens, really happy about this great information. But if there are unexpected cliffs, we are just proactive about that.
Yeah.
Community needs will be
Yep.
evolving too.
But I hope your overall framework would
be set.
Be lasting,
Yep.
but there's an update so you don't feel like you're doing the same big lift every single year. Go ahead.
I 100% agree with the chair on that approach. There's another component for me that has been a huge component to the success of this, and it's been you guys. It's been the staff. It's been the way you've approached the people that you've worked with, not, and I don't mean just the providers. We went on tours early on with the construction teams, and every single time I was there, and I've been on a lot of those tours, the construction teams went out of their way to tell me or somebody else that we had great staff and you work so well with them. That is the reason, in my mind, that we've had this 1% change in relationship to our budget. That's the reason the providers have come on site and move forward together. It's really the teamwork and the essence of you guys that have set the stage. My concern as we move forward is how do we continue that? How do you grow that in the people that you work with over the next 15 years? And how do we continue to have that type of leadership and investment, personal investment? Both you talked about how if you had to do it over again, you were very short staffed here. What was the component that made you work that hard? You know, and I really worry long term about, and this is one thing that does not keep me up at night, but I do think about maintaining that type of energy, that type of focus, because to me, that's where the success comes. It's the leaderships, it's setting the tone for all of the providers that come together. You said you stand back and watch the providers when VG comes in to get them successful. That's because you did it for them. And I really feel strongly about that. And I think it's something that you both need to be thinking about, and Mary, who left, about the succession planning and how do you bring people along in this work, because it is complex. I mean, if you think about the skill set required to work effectively with a construction crew versus mental health providers, that doesn't compute for me very easily, but you've done it. And that's something that I really hope you can grow throughout the organization. And my hat is so off to you. So congratulations. You've also managed us really.
So to our shorter tenure.
Sorry.
Thoughts, questions?
I mean, all of what Commissioner Treese just described and all the work you've all done is what makes the guy that walks in and comes back for his Coke comfortable. And that is at the end of the day, I think what matters is that person feels comfortable and is getting services. And so I don't have more to say other than thank you. And it's been a huge lift. I realize I wasn't here for much of the journey, but our community is going to benefit from this for decades.
And I'll be quick and to say congratulations and great work. I really do appreciate the two qualitative stories that you shared. And I think not that you're missing this strategic foresight on your end, but come back with the data on the quantifying piece of it and sort of tell us who these 1,000 people who are coming to utilize that are being serviced. Like, what's the breakdown? What's the socioeconomic? Is there some things that we need to consider to shift the paradigm of how we serve people in this area? So good work. I don't really have any suggestions of improvements. It's just great job so far.
Thank you.
Fingers crossed.
We hope you feel lost. You and the whole team. Thank you. Thank you very much for the update, and we look forward to a marvelous new year.
Well,
Alrighty, we are going to pause our work session here and reconvene at 1 o'clock. And we will convene in the auditorium and start our meetings at 10 past 10. Thank you. And Commissioner Willie will be joining us.